This is the clerk, just a courtesy announcement that we are now live on the internet and the YouTube feed. Thank you.
Good afternoon, Amy.
Good afternoon. Thank you.
Thank you. And good afternoon, Douglas.
Hi, can you hear me okay?
Sounds good, thanks.
Thank you.
And hello, Jonathan. Never mind, I'll leave you alone. Good afternoon, Edwin.
Good afternoon. Can you hear me?
Sounds good, thank you.
Great, thank you.
Good afternoon, Supervisor Lee.
Good afternoon. How's my audio?
Very good, thank you.
Great, thank you.
Good afternoon, Paul.
Hi, good afternoon.
Audio sounds good, thanks. Good afternoon, Rhonda.
Hello.
Sounds good, thanks very much. Good afternoon, Dr. Cody.
Good afternoon. Can you hear me okay?
Loud and clear, thanks very much.
Great, thank you.
Good afternoon, Jeff.
Good afternoon. Thank you for this sound check.
Loud and clear, thanks. And good afternoon, Dr. Morrison.
Good afternoon. Thank you for inviting me.
Yes, of course.
Vice Chairperson Lee,
Yes, can you hear me?
I sure can. We are waiting for Chairperson Subsidize, and I will keep you appraised.
Perfect, thank you.
My pleasure.
If anyone that I missed would like to do a last minute audio check, please go ahead.
Like Joe's really late, huh?
I just spoke to the district and he will be here shortly.
Okay, great. Thank you.
Recording in progress.
And good afternoon, Supervisor Simitian.
This is County Supervisor Joe Simitian, and I see the smiling face of my colleague, Supervisor Otto Lee, which tells me that we are good to go. My apologies for a moment or two of technical difficulties. So let's get right to it and call the meeting to order. I'll turn to the clerk for that duty.
Vice Chairperson Lee
Roll call.
Present. Present.
and Chairperson Simitian. Vice Chairperson Lee is here and Chairperson Simitian. Looks like Chairperson Simitian is having some technical issues.
I think we have them conquered, and I can now say present, which means that we have a quorum and are ready to go. Thank you, Madam Clerk. All right. That takes us then to item number 2, which is the public comment. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items. Once again, that's comment on items that are not on today's agenda, but that are properly within the jurisdiction of our committee. So let me turn to the clerk and ask if we have anyone who is in the queue for public comment.
We do have one request to speak, Mr. Chair.
All right, and I think we, under the rules of our board, give that person up to 3 minutes. So let's do that, please. We'll adjust the timer accordingly, and we'll turn to our speaker.
Ken Horowitz, you'll have 3 minutes to speak. The timer will start when you begin speaking.
Good afternoon. This is Dr. Ken Horowitz of our Health Advisory Commission. And I just want to give you a heads up. In a couple of months, our Health Advisory Commission will bring forward a report and hopefully a referral to the full Board of Supervisors regarding chronic disease. Our Health Advisory Commission has been working on this project for almost 2 years now, and we've met with a number of county leaders as well as the health aides of both Supervisor Simitian and Lee. And we're very hopeful that we can begin to start making an impact on chronic disease in our county. which, as you well know, is a major driver of spending by the county. So we have been meeting, and we will be giving you a report on December 8th regarding integrative functional medicine, which we hope to build a culture within the county health system. We have looked at the various models that are currently existing, including whole person care and your community healthcare program, which we think would align with our proposal to you. In addition, we think we can get reimbursement for our pilot program through the new CalAIM program that's been adopted by the state of California. So this is just a heads up to look forward in the next few months that we will be reporting to the Health and Hospital Committee, and we're hopeful that you will see it as a positive report, and we can make progress toward improving healthcare in our county. Thank you for your time, and have a great meeting.
That concludes our request to speak.
All right, thank you, Madam Clerk. Thank you, Dr. Horowitz. And that takes us to item number 3, which is our consent calendar and changes, if any, to the committee's agenda. Supervisor Lee, a motion to approve the consent calendar as contained in our published agenda, along with items 11 and 12, if you are amenable, would be gratefully entertained. And if I can get a motion, I'll second it. I'll speak briefly to it, and then we'll see if there's any public comment.
Yes, motion so moved.
All right, motion by Lee, second by Simidian, and that is for approval of our consent calendar as contained in our published agenda, and in addition, items at 11 and 12, and just an acknowledgement and reminder that items on the consent calendar are often very important items, but they're simply placed there because additional comment or question is not needed at this particular time in this particular venue. Let's see if we have any comment from members of the public. Do we have anybody in the queue, Madam Clerk?
No request to speak, Mr. Chair.
All right, then let's call the roll on the consent calendar as amended.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Consent calendar is approved. Thank you, Madam Clerk. Thank you, Supervisor Lee. Takes us to item number 4, which is recommendations relating to the medical staff and the various allied health professionals at our 3 hospitals. And as you can see from our agenda, we have under item 4, 3 different called for actions. The appointments and reappointments and privileges of various specified medical staff and allied health professionals, the approval of new enterprise-wide radiology privileges, and the approval of new enterprise-wide psychiatric privileges, psychiatry privileges. I think we have a presentation from the doctor. Forgive me, I have once again run into, there we are, I'm back. All right, Dr. Morrison, anything to say by way of introduction?
Yes, I'm Dr. Harry Morrison. I'm the enterprise president of the medical staff. I'm here to present the credentials report and answer any questions. One clarification I want to make regarding the privilege sets is that the psychiatry privilege set is VMC only. We do not, we did not submit enterprise privilege set for psychiatry.
Thank you for that clarification. Let me see if I can get a motion to approve with that clarification / correction from Supervisor Lee.
Yes, so moved.
I'll second. Let me ask the clerk if we have any comment from members of the public on this item 4.
No requests, Mr. Chair.
All right, then we'll call the roll and send Dr. Morrison back to his duties, if we may.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you. The motion carries.
Thank you. Motion carries unanimously. Thanks again, Dr. Morrison. Thank you, Supervisor Lee. That, of course, takes us to item number 5, which is a report on the Child and Adolescent Psychiatric Facility. Let me turn to our county staff and ask who would like to present.
Hi, Chairperson Subcommittee, it's Jeff Draper. I'll be doing the presentation today.
All right, go right ahead, Mr. Draper, and thank you.
Thank you. Our demo and excavation of the site have been moving on schedule. We have a couple of, in the last couple of days, we've had a couple of late breaking underground utility system concerns that have impinged on the project. Some things that we need to find a solution for. And so we're working through trying to come up with those solutions and a recovery schedule to keep us on time. In terms of the construction project, we've awarded a pre-construction agreement with the board's authority given to the county executive to WebCore this last week. And they've been working diligently on the work that's in that pre-construction agreement, which includes developing schedules and a price and a construction agreement with us. And we're going through red lines and all this other kind of stuff on the various documents. And so we'll continue that confidential negotiation as we move forward, hopefully bringing a construction agreement with WebCore to the board for consideration as early as the middle of November, but as late as the possibility the 6th of December. And really it's their effort to make sure that they have good solid agreements with all their trade partners that'll be driving that schedule to some degree. That's all I have.
All right. And that contract with WebCore is coming, you said when to our board?
Hopefully by the middle of November.
Okay.
That's what we're working toward diligently. It could slip till the 6th of December. It will not affect the overall delivery of the contract or the project, if you will, because we don't anticipate issuing them a notice to proceed with construction work until either late January or early February.
All right. Thank you for that clarification. Mr. Draper, I think you know that I have submitted for our full board's consideration on October 18th, a referral essentially directing administration to ensure that the management audit division that reports directly to our board and their subcontractors at Veneer have direct access to pre-construction meetings to provide us with some additional oversight and assurances about moving forward on a timely basis. And I just wanted to sunshine that today. I believe the item will be heard Tuesday, as I say, and if I know the action language was submitted on a timely basis. I don't know if the backup information has yet been posted, but if not, it certainly will be shortly. And then let me turn to Supervisor Lee, see if he's got comments or questions before I ask the clerk if we have anyone wishing to speak on this item. Supervisor Lee, you're muted, sir. There you go.
Okay, here we go. Thank you very much. So first, Jeff, I just want to thank you and the FAF team for working very hard with our administration and these different potential contractors to move this project forward. And also I want to say thanks so much for the update from last week's meeting on item number 9, because the report available today at the meeting is a modest update, so I only have a couple of questions. It talks about the preliminary schedule and the budget expected from the main BHSC building contract on October 3rd, and that was last week. So do you already have the preliminary schedule budget by now?
We have some indication of what our construction contractor is thinking, but of course we're still in negotiations and we're wanting to push as hard as we can to improve on that schedule. So we're still working the deal out.
Okay. Second question I have is regarding the demolition itself. The initial demolition date, I believe, is supposed to end by end of this year. And we are now extending that to sometime in February, which is a couple of months. Is that and that should not affect the end date that we're anticipating at this point, right?
Well, our intent is to issue a notice to proceed by the end of January, going into February. Mm-hmm. And that's what our construction contractor, potential construction contractor, is counting on in order to deliver the project. So far, the work on the site has been pretty clean, but as I mentioned earlier, we have a couple of late-breaking underground utility concerns where the mapping wasn't quite right. So we have to work through that schedule and that process in order to make sure that we can give you a recovery schedule that makes sense and provide you that date. But I talked to the construction contractor not long before the meeting. We think things are in hand at the moment. Things can always change.
Now on the excavation, I guess that's the thing about excavation, right? You don't know what you find when you keep digging. So let's say if there's some type of archaeological finds or of historical value, then that potentially could delay stuff, right?
So far, yes, you're absolutely correct, Supervisor, and hopefully we don't have that problem here.
Okay, all right. And then last question is, we did talk about the November 15th date, right? By having the construction contract ready for the board approval. Is there anything we could help to make sure that it would actually come on that date instead of December?
No, a great deal of what we're trying to get done depends on the prime contractors, a relationship in order to with their trade partners in order to get information put together so that we can have that contract proposed and put together for you.
Okay, all right, very good. And that's all questions I have. Thank you.
Thank you, Supervisor Lee. Let me ask the clerk if we have members of the public in the queue to speak to this item.
No request to speak, but Mr. Smith does have his hand raised, Mr. Chair.
Oh, all right. Dr. Smith, forgive me for missing that raised hand. Go right ahead, sir.
Sorry. Just wanted to expand on the question that Supervisor Lee asked. The board will remember that a few years ago in the process of construction of another building, we came upon coffins and burial sites that were from previous years when the hospital site was used for a cemetery. This particular site is not too far away from that. We don't think we'll find anything, but I do think it is worth emphasizing to the committee that the background and subterranean maps of the VMC site are very rudimentary. So it's very common that we run into things we didn't expect.
All right. Thank you for that. I'll call it gentle cautionary note, Dr. Smith. And I'll take the opportunity to underscore my earlier comments about making sure that the folks at Harvey Rose and their subcontractors at Veneer have access to pre-construction activity and pre-construction meetings and conversations consistent with earlier discussions and with the referral that'll be on our board agenda. Given the concern about delays that we've all expressed, I think it is important that both the public and our board have the reassurance provided by an independent third-party oversight organization like Harvey Rose / Veneer. All right, let's call the question. Madam Clerk, go right ahead. And I believe we have a motion from, well, I'm not sure that we do. Supervisor Lee, do we have a motion from you to move the recommended act?
So moved.
All right, thank you. I'll second, and let's go right ahead with the call on the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye.
Thank you.
That passes 2-0, and we'll say thank you again to all parties concerned. That takes us to item number 6, and this is our public health report on both matters related to COVID and Mpox, I believe. So let's go to public health, and who would like to present on behalf of public health?
Good afternoon, Chairperson Simitian and Supervisor Lee. This is Dr. Sarah Cody, Health Officer and Public Health Director. And I'll just provide you with a brief verbal update on both COVID and Mpox. To start with COVID, our case rates and hospitalization rates are both fairly stable. As you know, the COVID activity sort of stayed at a high plateau and has been drifting down. It does continue to drift down, which is good news. But as you also know, the case rates, which look quite low, don't really reflect the actual prevalence. For that, we generally rely on the wastewater, but that's also slowly trending down. The big news from today is that earlier today, the FDA amended the emergency use authorization for both the Moderna and Pfizer bivalent vaccines, authorizing a booster for the 5 to 11-year-olds. And significantly, the previous booster used in that pediatric population is no longer authorized. And subsequently, the CDC director expanded the recommendation to include bivalent boosters for kids 5 to 11. So now the only thing standing between kids being able to get their kids 5 to 11 being able to get the bivalent booster is the shipment. So we don't have the vaccine inventory yet of this new bivalent booster, but we hope that it will come very soon so that we can begin, we and others can begin offering it to kids 5 to 11. In addition, we will be updating our dashboard to include bivalent booster data, and we hope to have that in place by the end of today, actually. As far as Mpox, I would say also good news on this front. To date, our county has recorded 189 cases, but the good news is that the cases are really slowing. And since the beginning of September, we've had a small but steady stream, but it's certainly no longer rising, and it's manageable. Our cases continue to be primarily young men who identify as gay or bisexual, and a disproportionate number are Latino. And we continue very intensive outreach efforts to try to reach communities at risk, both for education and for vaccination. We've not had any shortage of vaccine. Our pharmacy is working diligently to onboard as many providers as possible, so the vaccine is available in many different settings. And to date, through all the different sites that are administering vaccine, just shy of 11,000 doses of vaccine have been administered. And that's both to residents of our county as well as to people who reside outside of the county. As far as residents vaccinated, so far, just over 7,300 residents have had at least one dose, and nearly 4,000 residents have had at least 2 doses. And so I think that we will be continuing to need to address Mpox for quite some time. I don't think that the infection is going to completely disappear, but the good news is I think we now have the tools and the infrastructure in place to support people who are most at risk. And that completes my report. I'm happy to answer questions.
Thank you, Dr. Cody. I'm not sure. I think Chair Simitian might be muted.
Thank you. You caught me once again. Go right ahead with comments or questions, Supervisor Lee. Then I have a comment or question or two myself, and then we'll go to the public.
Great, thank you. Thank you very much, Dr. Cody. Certainly the stable rates and the fact that even the wastewater shows that the activities is drifting down are definitely good news. And the FDA EUA, the emergency use authorization for the bivalent for 5 to 11-year-old is exciting news, but of course it will probably take us at least a few days or a week before we get the shipment. So we'll just be getting the appointments ready, but it won't be ready to go out until they arrive, right?
That's correct. I mean, we're ready. We just need the shipment to arrive.
Are these the lower dose compared to the normal adult dosage?
I can't give you details on the pediatric booster dose. I imagine that the dosage is just like the prior booster dose, except that it's formulated to protect against both the BA4, BA5, and the original strain.
Right, okay. So right now on the bivalent booster, the situation seems like people are just so fatigued from the whole COVID pandemic with like very few people wearing masks. At the same time, when it comes to talk about bivalent booster, it does not seem to have the type of sense of need or urgency at all. And so the percentage of people getting this latest vaccine seems to be very low from my observation. Is that what you see?
Yes, I think your read is absolutely correct. There is significant fatigue and a loss of a sense of urgency. And so the uptake of the bivalent booster has not been as brisk or as broad as compared to the uptake of previous vaccines and boosters. Of course, the bivalent booster is recommended for now everyone 5 and up, but we are especially anxious to see people 50 and up get that bivalent booster. We never know what the winter holds, but the last 2 winters have not been kind, and we really urge everyone to get their booster as well as their flu vaccine. We, as you know, have a number of different media campaigns and a lot of social media channels to try to reach people, but it's tough sledding at this point.
Right, it's like the small print in every stock, advertisement, right? Past performance is no guarantee of future income. So we don't know whether, if you look at the past performance, the fact is that during, the colder months, the COVID variants tends to be very, very strong, and that's why our case rates also go up as well, kind of like a flu vaccine, right? So
yeah, gather and traveling are not good for
Right.
respiratory. I mean, they're great for respiratory viruses. They provide lots of opportunities, so not good for humans.
Right, and so for example, I myself did get both the flu vaccine and the bivalent vaccine this past Saturday, and I just scheduled so that my Sunday I could be able to rest, and I practically was so fatigued that I slept most of the day, and felt great by Monday. But in any case, certainly it's something that we need to get a word out. So, Dr. Cody, what are we doing to push on the PR campaign in order to remind people how important it is? Because trying to convince individuals who is basically don't believe in vaccines is one thing. That's almost mission impossible, as we know. But for those who clearly have already gotten the vaccine or even boosted, there's really no hesitancy here. But how can we make sure that they understand the issue of the waning, right? That it's been many, many months. Number one. Number two is the fact that the new variant will likely not be as protectable by whatever they have left in antibodies, and that's why the new bivalent vaccine is so urgently needed to be put in. What can we do?
Yeah, so this has become another challenge in our pandemic response, because I think the combination of being almost 3 years in and the fatigue that sets in, as well as right now a member of the public may not be seeing the impact of COVID and may not feel the urgency, but because everything's pretty much back to normal. The weather's nice, and not so many people are getting sick. So 2 thoughts. One is, as I mentioned, we continue to do our communications team doing everything that they can to reach people that they think they can move. And much of that is through individuals telling their story, their family's story, and using the information we have about how people react, appealing to their desire to protect their families, for example. And there, what we may see is a little bit of a delay and uptick until we begin to see a surge in COVID activity, and that will likely drive another group to get their bivalent boosters.
Right. So I think whether we are using the TV ads, social media, print ads, whatever, words of mouth, right? I really do think that we need to up our game in order to make sure that folks are feeling at least some type of urgency to go get themselves registered. Now, are there any groups like schools campaign we could do on this, or even going to various community groups that we could try to get this word out?
There may be, I don't have all of this just top of mind, but maybe we could sort of gather up a list of the things, the approaches that we have going currently, and share that back.
Okay, yeah, I think I think this is the time to do it, because I certainly don't want to wait till the weather is colder, and then by the time when COVID is really hitting, as we know, the vaccine, even though after you get it, it'll take at least 2 to 4 weeks for it to really activate and work well against the bug, right? So, well, if it's too close to the time when you're catching it, the vaccine might be too late. So I think this is really the time to get it. So let's not wait too late on. So if we could get the word out, I certainly appreciate it.
Yeah, I would say that we have another opportunity to capture the public's attention when the bivalent booster for the youngest children becomes available. And so that is an opportunity we will be taking to emphasize the importance for the people that listen to their local news. We'll hear that the message that way. Yeah.
Bring your whole family over. And
that's right.
All get vaccinated in one time to prepare for the winter. Something like that, I think would be great. Yeah. Okay. You mentioned 5 to 11. So right now, I believe we still have a infant vaccine for the 6 months and to 5 years, right? So those will still be using the old vaccine.
That's correct.
Okay. All right. Good. All right. The other questions I have is, I guess with Mpox now, it's do you see Mpox as considered an STI?
It's not being called an STI per se, but what we do know and see in our local data is that the infections are primarily among people who have had sexual contact with one another.
Okay. And if this were categorized STI, is there any effect specifically in terms of how we administer this?
Well, there, as far as programmatically, we are folding our Mpox prevention and response into our program that also does STI and HIV prevention and control. That's our sexual health and harm reduction program. So the Mpox activity is being folded into that program. As far as funding, the funding streams come in all sorts of different ways, and there is now late breaking news, a small amount of funding that will be coming from the state to local health departments to address Mpox.
I see. So I just want to make sure that we, of course, be very aggressive with state to make sure that we get these type of fundings. Since like almost 200 cases of Mpox already in our county.
Yes, and we are receiving funding from the state and their formula. I can't remember all of the variables, but basically it looks at the burden of disease that a county has experienced and reported, as well as other underlying risks in the population where we know the risk will continue. So we have received our funding allocation. I mean, we haven't received it. We've had word that we will receive it, and it's welcome.
Good. Is there any more necessary outreach you think we need right now on the vaccine mpox information to the public?
I think that the, as you know, over time, we've gradually expanded eligibility to who's eligible for the vaccine, and done that in concert with others in the region. And the state has also expanded eligibility. I think at this point, the partnerships that we have been very productive, and we continue to do outreach and education and encourage people at risk to be vaccinated. I will say that the pace has slowed down. So, as you remember, we certainly had demand far outpacing supply early on, and then it kind of matched up, and now we have more supply than demand. And we're needing to do sort of higher touch, higher resource activities to reach people who need to be vaccinated but have not been vaccinated yet. We also did quite a bit of work to understand barriers to vaccination, what might be keeping people from being vaccinated. And it's sort of the things that you might imagine, everything from I didn't realize that I was risk and needed to be vaccinated to I'm worried about it for one reason or another to I'm having difficulty getting to a site.
Great. And that's all the questions I have. Thank you very much, Dr. Cody, as always.
Thank you.
Thank you, Dr. Cody. I've got a couple of observations, and then I want to try and pull both you and Dr. Smith into a conversation about who's doing what in terms of providing the bivalent booster vaccinations. The first is, I think if COVID's going to be with us for a while, and it appears that that's the case based on all indicators, including your remarks, then maybe we need to move from hoping or expecting that people act with a sense of urgency to hoping that they develop the habit of getting a booster when that's called for. Now, that's a little hard to do, I think, when we're still learning as we go, when the booster formulation is changing, the timing is uncertain. But do you have thoughts about, Dr. Cody, about this becoming a habit rather than a response to an urgent circumstance? I know for years, every fall, you and I would have a brief exchange where I was reminded once again about the importance of getting a regular flu shot. Thoughts?
Yeah, I think that's an excellent thought if we think about it as how to develop and instill a habit rather than being in a reactive mode to an emergency. It's difficult to stay in that reactive mode for a long duration of time. One of the challenges, I think, is around predicting the future and communicating an expectation. So, for example, how frequently will people need a booster? So when they're thinking about developing a habit, what will that habit need to look like? And it may be that the habit is that you get your COVID booster in the fall along with your flu shot, or it may be that you need to get a booster more frequently because of what's happening with evolution of the virus and a variant becoming, quite different than the variants that we've seen before. So that's a challenge, a surmountable one, but one challenge.
Thank you. I want to sort of plant the seed of that thinking or reinforce it if the seed has already been planted. But I do think we need to think about how we can stop the necessary reactive mode, lurching from moment of crisis to moment of crisis, and try and start to be a little bit more masters of our own destiny, if such a thing is possible at some point. I should say at this point, I want to express again and the appreciation that my constituents and I have for the North County facility that's in the space in Mountain View. Although I have to say what's interesting and a source of some concern is that there seems to be sort of a binary divide here between those who are aware of the facility and appreciative and those who are unaware that there is in fact a convenient resource handy and that there's a need to access it and that it's quite close by and convenient. So I am pressing on our organization to continue with public awareness campaigns throughout the county, including folks in the North County or close proximity to the North County who would find that site convenient, because I still think we have work to do there. And I do want to express my thanks to folks in the communication side of the pandemic response team. I understand that there's more in the works, but we hear from you repeatedly the concern about the lack of urgency, and to which my reaction is always, well, if it's urgent, then it seems to me it ought to be urgent that we're communicating to people that there is a resource available. And so I share that with both you and Dr. Smith, because putting the resource out there, but then not backing that up with a really robust communications and public affairs strategy is, I think, not the best of all possible strategies. I'll let it go with that. And then the issue that I wanted to spend a little bit of time with both you and Dr. Smith on is thank you for the information about COVID-19 vaccinations administered to Santa Clara County residents, sorted and segmented by healthcare provider. Dr. Cody, do you have easy access to that page by any chance? I want to give you a minute if you need it.
Let me see. This is, I believe, from the data presented at the last Board of Supervisors meeting. Is that what you're referring to?
And I'm not sure this works, but that's the document I'm talking about. And Dr. Smith, if you can let us know that you're standing by as well, that would be helpful to the conversation.
And
yes, I'm here and I'm trying to find the data myself.
I will email it to you, so you, in case that helps.
I don't know if this is easier or harder than the old days when we just got up and handed it to somebody, but thank you for that. Pre-COVID.
And
tell me when, Dr. Cody.
well, I have it up, but
Okay.
now my PowerPoint is not responding, so that will be difficult to share with Dr. Smith, but I will keep trying.
All right. And here, so what we have in front of us, or what we had in front of us, and which I've asked for a little time to talk about today, is a list of providers. So retail pharmacies, Kaiser Permanente, our own Santa Clara Valley Healthcare, other healthcare entities in the county, the folks at Palo Alto Medical Foundation, Sutter Health, healthcare entities outside of Santa Clara County, Stanford Healthcare, El Camino, their community health clinics. And what the chart, of course, indicates is the estimated number of folks who are covered by each of these various providers, and then the percentage of the county population that they serve, and then the number of doses that they've administered of the booster, and then the percentage of boosters that that represents. And Dr. Cody, I'm just going to pick one example because it's the one I have the most experience with, because it's my provider, and that's the Palo Alto Medical Foundation, which is operates under the auspices of the larger Sutter Health organization. And according to the chart that I'm looking at, there is an estimated 320,000 residents who are covered or served by the folks at PAMF Sutter. And then 16.5% of the population is the estimate of how much that represents. And then the number of bivalent doses that are administered is 29. Thank you for that. Now you're looking right at the center of the screen here, 2,919. And then 3.2%. And thank you, because the visual really does make it a little easier to keep track of what I'm trying to talk about. And so here's what I am struck by, and I want to precede my concern and critique and ask you to hold that steady if you can now. Look, there are untold thousands of folks who have just given of themselves over and over and over again at every one of these institutions. And I certainly know that from my firsthand experience and from the experience of my constituents at the Palo Alto Medical Foundation and Sutter. That said, organizationally, in terms of the corporate policy, I'm looking at what appears to be an indication that with 320,000 residents served, that fewer than 1% of that patient population, that would be the third column, 2,919 doses have been administered. As I say, that is less than 1%. Now, you all have repeatedly, both Dr. Smith and you, Dr. Cody, exhorted us and our constituents to understand the urgency of the matter and to take the necessary steps. And, here we are with data from the end of September, I think it's September 28th, that says that, this is a well-established organization with significant resources that has managed to get the booster out to less than 1%. And, another way to look at this in terms of who's doing their share is to say, wait a minute, 16.5% of the population in the county, but only 3.2% of the doses that have been administered to date. So what is the, forgive me, I'm rarely speechless, but I just, we've been at this for 2.5 years and here we still are. So what does it take to get everybody to step up and do their part? Dr. Cody and Dr. Smith.
Well, I think this has been a constant struggle. As we've talked about before, the health systems other than our system do not perceive themselves as participants in public health, needs. And so they're content to let it be the public health system's problem. We've pushed them. They continue to be reluctant to take over larger responsibilities. Some of them have actually been trying to notify their patients, but none of them are actually performing at the same level that the county is performing. So other than, a legal compulsion, I don't know how we could move ahead and get them to comply since they are private entities. We can't force them other than with legal threats.
Dr. Cody, thoughts?
Well, I would certainly agree that this has been a challenge throughout the pandemic and disappointing throughout the pandemic. I can only surmise that it has to do with a financial disincentive to do this, and that it must not be to their advantage to scale it up. And certainly with retail pharmacies and the counties stepping up, perhaps not a perceived urgency in providing the service because there are others who will carry the water.
Yeah. Have you given any thought, Dr. Cody, to issuing a public health order directing these folks to step up?
Well, I think this is a very broad problem. So to me, it's about whose responsibility is it to provide preventive services such as vaccine to the population? Is it the healthcare provider? Is it the public healthcare system? Is it the local governmental public health department? I mean, I think that it's the responsibility of the healthcare provider to provide a preventive service for their patient. I'm not sure that a health order in a single jurisdiction by a single health officer for a single disease unnecessarily makes sense is the best way to address what I think is a larger problem.
Can you understand my frustration, Dr. Cody, if we have empty office buildings, we have a mask requirement here in our own county, and yet we have fewer than 1% of a healthcare provider's patient population being administered a booster under those circumstances?
I share your frustration. I absolutely share your frustration.
All right. Well, we're 2.5 years into this, Dr. Smith and Dr. Cody, and I think, the public might reasonably understand that in the first 3 to 6 months of a healthcare crisis, a pandemic that was in many ways unprecedented, and if not unprecedented, certainly unanticipated. But 2.5 years in, I think people reasonably expect that we have this sorted out. Dr. Smith, does that mean that going forward, it will of necessity be the policy of our county to provide vaccinations as needed to all 2 million residents of the county, notwithstanding the fact that our own client population or patient population is a relatively small fraction of that, maybe 15% or so?
Well, a complex question. We've explored potential vehicles to try to apply pressure to the outside agencies and businesses. Some of this needs to be discussed legally in closed session, but suffice it to say that the most likely scenario is actually an ordinance on the local books. Public health order has some problems associated with it. I don't want to go into too much detail since this might end up being a legal issue, but sadly, because of the structure of our healthcare system, private providers have much discretion about how much of particular services they offer, and they don't feel compelled to offer more than they already do.
All right. Well, let me ask this question then. And forgive me, I can't see on my screen if we have County Council President present. Mr. Press, are you with us today, or some other representative of County Council's office?
Yes, I'm here. Good afternoon.
Thanks, Mr. Press. Nice to have you with us. Mr. Press and Dr. Smith, I'd like to ask for an off-agenda confidential memo on the tools available to our county, whether that be the board or the public health officer, to compel participation in a robust program of vaccination. And I'd like to ask that that be scheduled for a closed session of the board, Dr. Smith, if you and Mr. Press deem that the appropriate venue for the conversation. Do I gather, Mr. Press, that that view is consistent with your own about how we might best proceed to have this conversation? I like to do things in an open and public fashion whenever possible, but if this is the only way we can have the conversation, then so be it.
Yeah, so as you probably have recalled from some of our prior discussions, I'm reluctant to discuss different legal strategic options in a public forum, just because we want to have the freedom to, think out loud and discuss different options confidentially. So whether it be by confidential off agenda by itself or a confidential off agenda memo in conjunction with the closed session, either of those options I'm certainly comfortable with. Obviously, I'll need to confer with the county council about this as well. But again, in general, I think best that we have our strategic legal conversation confidentially. And then once we all land on something, then we can, of course, implement that and vet that publicly as we must.
Thank you. Dr. Smith and Mr. Press, I just want to make sure as a process matter, I'm about to make a motion directing the County Counsel's office to provide such legal information in a confidential off-agenda memo, and then also to agendize this for our closed session. Dr. Smith, is that sufficient to ensure that it will in fact land on a closed session agenda in the near future?
I think that's sufficient. County Council develops the closed session agendas, but they are very responsive to the board, so I don't think you have a problem with that.
Mr. Press?
Just echoing Dr. Smith's comments, I will certainly relay this to the County Council forthwith, and I'm not concerned that this will make its way to closed session.
Okay. Do I take that, just to make sure we don't have a double, triple negative there? You're not concerned that it would not make its way, yes?
Correct. Thank you.
Thank you. Then I will make that motion and ask Supervisor Lee for a second.
Yes, I'll second it.
Thank you. I appreciate the courtesy, Supervisor Lee. I will go to the public in a moment for comment, if any. But Dr. Smith and Dr. Cody and Mr. Press, now that we've pulled you into the conversation, ordinarily I don't share my personal experience. I think it's important that all of us take a broader view, have a slice of life, not take on undue importance or influence. But in this particular instance, I was able to test out my theory by contacting the folks at the Palo Alto Medical Foundation Sutter Health, ask for an appointment for a booster. And I was informed by a very capable and professional call center staff person that no, you cannot get a booster in Palo Alto. Fine, I'll go to Mountain View. No, there is nothing available in Mountain View. Okay, how about San Carlos? No, nothing available there. That meant that I was then, Dr. Smith, in the position of saying, well, there's always SCC free vax at our county website, which is where I went, and I went ahead and signed up for an appointment at our North County site in Mountain View, and have been through that process, which was smooth and capable and professionally administered, which is what I'd heard repeatedly from my constituents. So I want to be very clear that I'm not saying that an isolated anecdotal experience is evidence. That's why I asked for the chart. And when the chart says that, one provider, as an example, has 16.5% of the patients, but has delivered only 3.2% of the vaccines, that tells me that, by a factor of 4 or 5-fold, someone's not handling what I would call their fair share. And when, as I say, less than 1% of the patient population in that same provider's care has been administered a dosage by Sutter, that tells me that we've got a problem. And even if you look at retail pharmacies, the number of doses there, and just estimate that, the percentage of those folks who got a shot from a pharmacy is roughly equal. It's very clear, to Dr. Cody's earlier point, we're not getting it done. And I have made the case from the beginning that understanding the importance and need for outreach to folks who are vaccine hesitant or resistant, that if we can make it easy, make it simple, be clear and concise in our direction to folks who want to get the vaccine, that's the path towards a quick adoption, or quicker adoption at any rate. Ultimately, Dr. Smith, I ended up as an individual patient here being a burden on our county healthcare system, rather than being able to access the booster that you all have been recommending from my own provider. I'll stop there, but I just I'm hearing this story enough that I have to believe that this is not an isolated case, and that the data supports the notion that it's not simply anecdotal. It's consistent with what the numbers show us. Dr. Smith, I see your hand is still up. Would you like to get back in on this conversation?
Yes, I'm sorry if you don't mind. First of all, you're not a burden to our health system and you never would be. So I'm glad you got your shot. But secondly, the issue that you're describing that the committee is discussing at this point goes far deeper than merely vaccines. You know, we are focused on vaccines right now, as we appropriately should be. But I'd like to point out that there are entities, which I won't name, with clinics in Palo Alto that currently have all of their primary care panels filled, which means that no new patient can be seen in primary care clinic in Palo Alto if they're a member of this insurance system. It goes to point out the scarcity of resources, even in one of the richest counties in the nation, and also the focus that private corporations have on profitability rather than on patient care. And I'm extremely concerned about it, as it might will negatively affect our constituents. It already has negatively affected our constituents.
Forgive me. All right, obviously to be continued, we have the motion on the floor, which, by the way, incorporates the receipt of the report. Let me turn to the clerk and see if we have anyone standing in the queue who would like to comment on item number 6.
One request to speak, Mr. Chair.
All right, let's go ahead and hear from that individual. Up to 2 minutes. Thank you for posting the time.
Victor, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Okay, thank you. So I'm Vic Ojakian. Just quickly, since I heard Supervisor Simidian's comments, I'm also a patient client at Palo Alto Medical Foundation. And yes, they have some delays in getting the vaccine out. So both my wife and myself, almost instantaneously, got appointments at other local facilities and got our shots almost for both the flu and for the COVID variant. We got those almost instantaneously. So the vaccines are available. They might not be available at PANF, but they're available locally and easy to get, and they're available at no cost. And then maybe to clear up something that I heard Supervisor Lee mention, I'm sorry to hear that you had a reaction, or your Sunday was spent dealing with your vaccination. But I've had 5 vaccinations now for COVID and had no reaction to any of them. So I think most people should understand this is a smart and good thing to do, and go get your vaccination. Now, I was on for a different issue, the suicide prevention report, but I have another meeting that I have to attend. So I'm just going to make a quick comment about that before you even get to it on the agenda. This has separate to do from the specific actions that our committee has taken, more to do with the whole history of the fact that we started in 2010 doing the work on suicide prevention in our county. We're one of the first counties to do that. And I think our success, and I feel like there has been some, is based on sustainability. The fact that we've kept a program going when some people react to deaths in their area, and then put a committee together and then let it wane. So my final comment would be, keep supporting what we're doing, because it's invaluable. And thank you, and I have to go to a different meeting now.
Thank you very much.
That concludes our request to speak, Mr. Chair.
Thank you. All right, that brings it back to you and me, Supervisor Lee. I'm going to call the roll in just a moment on the motion, which is to receive the report and to direct County Council and administration as indicated. But I want to engage again with Dr. Cody and Dr. Smith. Dr. Smith in particular, I was struck by Mr. Ojakian's comments that his experience or his observation underscores the very point I'm trying to make, which is you can get the vaccine. So it's not that you can't get it, it's that some folks are not stepping up to deliver, and that's putting a burden on others to step up and deliver. And that is the concern that I have. And here we are 2.5 years later, still struggling to wrestle that one to the ground. Supervisor Lee, anything before I call the roll?
Yeah, I just want to supplement that. This past Saturday, we had the Day on the Bay. Like I mentioned earlier, we received both the flu shot and the COVID bivalent shots. I just want to give a shout out to a few folks. Eileen Steiner, JD, who is the account manager of the OptumServe, partnering with the California Department of Public Health, and her team did a great job of administering a couple hundreds of vaccines for the COVID shots. And also for the flu shots, we have Serena Sai from Director of Primary Care Operations and Catherine Cummins, Ambulatory Service Manager, and their team. Really efficient, and there wasn't much of a wait, and everybody who wanted a shot, get a shot. So that was great, and I just want to give a public shout out. Thank you. That's all I have.
Thank you. Call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Motion carries unanimously. Thank you. We look forward to following up on that one. Item number 7, mental health parity. Let me ask who's going to begin the presentation from our team here.
Yes, good afternoon, Mr. Chair, Person Simidian and Vice Chair Lee. My name is Renee Santiago, I'm Director for the County of Santa Clara Health System. And here with me is Amy Carta, who will do the presentation on this particular item. But before I turn it over to her, I wanted to highlight a couple things that under your leadership, the Health and Hospital Committee has focused on. As you know, and the general public might know, our county declared behavioral health as a public health crisis. You have been receiving monthly reports from both the county executive as well as the behavioral health department. And Parity is the foundational policy which we're all grappling with. You just talked about vaccines and private systems. Similarly, in behavioral health, parity is both a foundational and aspirational issue for us. What it simply means is that people suffering from a mental health or substance abuse disorder should be treated fairly and equally like if it was any other healthcare or medical care problem, particularly by health insurers. 74%, nearly 3/4 of our residents in our community are actually covered by private health insurance and not necessarily Medicare or Medi-Cal. In fact, as you heard from our behavioral health department, in many cases, Medi-Cal is the solution to many of the problems people encounter in other sectors. So what we're proposing here today, beginning with item 7, is a very new approach. I don't think any other county is doing what we're proposing to do under your direction. One of them, as Amy will indicate, is the development of an outreach and education, so we all have a better understanding of what parity means, what are the gaps and loops and patchworks that exist, and why people cannot find access to mental health and substance abuse services in our community. The item number 8 is an innovative pilot that builds on our local experience of having dealt with gaps in medical care to do that also for behavioral health and substance abuse services. You'll be hearing from Laura Rosas, our CEO for Valley Health Plan, who will be presenting recommendations related to that particular piece, particularly for people with moderate incomes that are not receiving services. And then item number 9 will be a report what we as an employer are doing working with our insurers so that in fact our employees also have timely access to mental health and substance abuse sources. So without any further ado, I'll turn it over to Amy to give you an update in terms of agenda item number 7.
Good afternoon, supervisors. The initial referral, a number of reports to the committee, and Mr. Santiago's comments really address the importance and the need for mental health parity. This agenda item addresses the first referral regarding options to improve mental health parity for county residents. The written report details a series of bills on parity requirements and oversight. It summarizes the patchwork of federal and state legislative and regulatory actions around parity, all of which are rooted on insurance. Combined, the federal and state parity laws have a foundational impact for those Californians with insurance coverage and a mental health diagnosis. And yet the patchwork means parity is not universal. As you know, there are many efforts underway in Santa Clara County to improve services and expand capacity to address behavioral health needs. And in considering operations, attention needs to be paid to aligning and not duplicating efforts. To identify the opportunities to improve parity, a work group was formed, and it included representatives from Bay Area Legal Aid, the Behavioral Health Board, the Behavioral Health Contractors Association, El Camino, Kaiser, Momentum, the National Alliance on Mental Illness. Consistent themes emerged from our meetings, pointing to the importance of policy as well as outreach and education, especially on how to access care and services, understanding rights to access care, the changes in recent laws, and the process to access medically necessary services. Resources and information to help assist the consumer, the community, and employers, and where to go if additional assistance is needed. Through the work group's conversations, it's become clear there are many barriers to achieving full parity. To date, the options for improving mental health parity fall into two categories: policy and education. And to achieve meaningful progress, changes are needed in the policy environment. We'll begin by identifying where there are gaps in the patchwork of parity laws. And an education campaign would enhance understanding regarding laws and regulations and help make it easier for people to access care and services and resources. Specific information and resources would be developed and an outreach campaign. One-time funding from the Mental Health Services Act has been recommended to support the education campaign, and we can provide updates to the committee as the planning work progresses. And with that, I'll say thank you and see if there are any questions.
Supervisor Lee, I'm going to turn first to you.
Thank you, Chair Simitian. First of all, thank you very much for this very insightful report. And I think the point that has come up repeatedly through these discussions is about the ability to get the word out, the outreach and the education. Do we have a timeline of when this type of educational outreach and campaign will begin?
At this point in time, we don't. We will work on developing that and we'll bring that back to the committee.
Okay, and that's all I have for the time being. Thank you.
Thank you. Supervisor Lee's question mirrored my own. And I think, Ms. Carta, I want to thank you, and I don't want this to be misunderstood. I want to thank you for the brevity of your report, because I think you crystallized a lot of information in a very brief period of time, and essentially said there are two things that need to happen: better policies and real education and outreach. So I think, being realistic about how long policy change takes, that's going to be a while in coming, and we hope we make more progress still, obviously. I guess to Supervisor Lee's point, I gather from what you were saying that, notwithstanding the fact that there needs to be policy improvement, the rights that people do have now is in your view something that folks can only take advantage of if they know about it and how to take advantage of it. Is that a fair restatement of what you're sharing with us both today and in the report?
I believe so. Thank you.
So if I have a sense of urgency about this, and my goal is to make sure that folks out in the community know at the earliest opportunity that they have a right to mental health services, particularly as Mr. Santiago was pointing out, folks who are covered by private insurance and who may have that right and not even really fully be aware of it. Is that the kind of campaign that you're anticipating, thinking about developing here at the county level?
We'll be working with our partners on the committee to develop the best messaging and the campaign. The providing information to individuals in our community in terms of what the laws say and how they can access services are two very important components that we'll definitely dive into.
And you talked about timeline and said basically too early to tell, but when should we be circling back? Either if you or Mr. Santiago can respond, and say, how are we doing? Where are we? And when are we going to actually be out there in the community sharing this information?
We can bring a report to the committee in early spring and be able to share the information by then. Sort of
Go ahead. Sorry.
I said that keeps the current cadence of reporting going and looking at the work that we need to accomplish. That would seem to be a reasonable timeline.
So if I have a greater sense of urgency, Ms. Carta, Mr. Santiago, or Dr. Smith, is there any reason I shouldn't just go to my office budget, take out an ad in the local newspaper that says, insist, you have a right to mental health care coverage, contact your insurer if need be, and just try and start the conversation that way? Some reason that's not, I just, as I say, I worry that time will roll by and that, pursuit of the perfect will be the cliched enemy of the good. Dr. Smith, I see you leaning in, I think.
Yes, no, there's nothing to stop you from doing that. Everyone should be aware that they have a right to mental health care in an equitable way. Obviously, as Amy described, there are other ways around that for the provider, in terms of limited access and limited providers, but everybody should know they have the right. And if they don't have a provider willing to provide that care, they should find another provider.
Okay. Well, we'll work through these issues with you all, Ms. Carta, Mr. Santiago, Dr. Smith. But again, I think the sense of urgency is quite real. And I know there are a lot of stressors in our organization, but one way to reduce those stressors would be to get private sector insurance providers to step up and do their address their legal obligations to provide care. The other thing I would say is that it seems to me that one way to move in the right direction is to mobilize patients and the families of folks who need and deserve and are entitled to this care through greater engagement by the public. So if that's what it takes, that's what it takes. I think we've all had too much experience, and their data is pretty clear that a lot of folks are not getting help to which they are legally entitled. All right, let's see if we have anyone here to speak to this item. Madam Clerk?
No requests, Mr. Chair.
All right, Supervisor Lee, anything else, or would you like to make a motion to receive the report?
Yes, so moved.
Motion by Lee, second by Simidian. Call the roll, please.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. And that measure passes unanimously. And I'll say thank you again and exhort whatever urgency we can bring to the effort, please. That takes us to item number 8. Mr. Santiago, are you going to help lead us into that conversation?
This is Laura Rosas, who's our CEO for VHP, and will be presenting.
All right, thank you. Ms. Rosas, welcome and thank you. Go right ahead.
Thank you so much. Good afternoon, Supervisor Lee and Chair Simidian. So I'm going to speak today about the Primary Care Access Program, which I know you're well aware of. and how we're going to leverage that program to expand access to behavioral health. So just to go over where we are in terms of what we were doing a year ago, we were talking about expanding PCAP, which is how we refer to the primary care access program for current enrollees, do a lot more outreach, expand the eligibility to 400% as this committee led and the board led in that expansion, build a quality program that would increase funding for the clinics and really reward access and quality, and reimburse the clinics for recertification, and align these benefits with the US PSTF, the Preventative Services Task Force, and then include all the standardized codes and reimbursement and standardizing the co-payments and other contractual areas. So to give you some sense of where we are today, we did consolidate the PCAP operations across VHP and the health system. That is completed. And so that was done by January of this year. We redid all our contracts with the CHCs to include this expansion for PCAP. We are working on our quality program. This is in process, and we're implementing Epic, as are the clinics. So everyone's in full implementation at this point. That will help a lot with the data sharing. And we are working on an expansion of access to behavioral health and mental health. That had been something that was discussed earlier, as well as an expansion on dental and vision. That's in process. And for phase 2 in 2023, we're going to explore partnering with the clinics on some alternative payments, proactively educating and supporting enrollment of county residents unable to access other insurance options, and working with the clinics really to leverage all of that Epic data sharing to improve quality and care. As of course you are aware, there was a board referral requesting the creation of a pilot to subsidize outpatient mental health care at nonprofit clinics for the middle income. And the ask was to identify residents for a program and how they could be served. And so that is what we are bringing you today, is our proposal for how to create that expansion. So we're proposing the leveraging the PCAP program because we have an existing infrastructure in terms of claims and value-based payment program and the programmatic support. We already have the community clinics and other providers under contract with Valley Health Plan, and we have those established workflows across VMC, VHP, and the Community Health Partnership, as well as other stakeholders. There's also a public familiarity that's growing with the PCAP program. We've established marketing materials and communication pathways into the community, so people really know the program and they're getting to be more familiar with it. And we successfully expanded the 400% of FPL that was requested by the board this year. So we've got a good, strong platform to now build upon. And so proposing this expansion, what we're stating is a full continuum of mental health care, including severe mental illness and outpatient substitute treatment for the low to middle income. And inpatient services are currently available through VMC HAP, which is the health access program at the hospital system. This would include pharmaceuticals through the VMC pharmacy and a Better Health pharmacy. And here you see current behavioral health providers that could be part of this contractual expansion that are already part of it or would be included in this expansion. So we've already got many of these providers under contract with VHP. We could expand this as well. So some of the considerations are that the current program for PCAP is up to 400% of FPL. The HAP program, which is the inpatient side of the charity program at VMC, actually goes up to 650% of FPL. We're proposing increasing PCAP to 650%, so it'll align with HAP. That's one reason. The other is that it'll actually help with referrals and keeping continuity of care and post-discharge care, and expand. If we're going to expand to this mental health piece, then it makes it just easier to administer the program across the board rather than having different levels. And given the cost of living in the county and the salaries and what it really means to be middle income in Santa Clara County, we think it makes sense to go up to 650%. and that this will improve the alignment for this population and reduce that complexity and ensure that people are receiving the right care in the right venue. Both nationally and locally, behavioral health resources are impacted to an unprecedented degree. I'm sure you have seen many articles and featured reports and all sorts of media. There is a lack of providers. We're proposing to contract first with our community clinic partners, but also to supplement with our private behavioral health network to ensure patient access. Telehealth has been proven to increase access and patient satisfaction for behavioral health in particular, and we definitely want to include the VHP telehealth services in PCAP. We have MD Live currently. We're looking at other potential partners as well. A lot of behavioral health patients like telehealth for its convenience, its privacy. So that's definitely going to be part of the PCAP expansion. We're looking at launching this in a phased approach in the first quarter of 2023, and estimating for the behavioral health side about a cost of approximately $1 million a year. And that concludes my presentation, and happy to take questions.
Thank you. Ms. Rosas, my colleagues sometimes tease me about my frame of reference when I say, now, if somebody asked me about this at my sidewalk office hours, how would I explain it? And if I were sifting through all of that really helpful and good information to sort of say, bottom line, here's what we got in the way of report back, the administration is now prepared to say, we have an existing PCAP program that provides healthcare coverage for folks who are uninsured, and we are now prepared to make that program available to a substantially greater number of folks based on a higher income level. Yes?
Yes, that is correct.
And number two, Supervisor Subsidize, you and your colleagues on the Board of Supervisors have asked us to ensure that we can make mental health services available to the so-called missing middle in terms of income. And we're now prepared to do just that, using not only the existing PCAP structure, so we don't have to spend as much time and energy ramping up, but also at the same higher income level to make sure that it truly does serve the so-called missing middle. Yes?
Yes, that is correct.
All right. Well, then I ought to say, hey, good news, since when we are struggling, I want us to confront that. I'm going to go back to Mr. Santiago, if I can pull him back on the screen for just a minute. Mr. Santiago, when I talked to you in advance of today's meeting, if I may say so, I hope I don't put you on the spot, but you seemed pretty proud of all this. Tell us why. Go ahead. I'm going to give you free rein here to feel good about the work we're doing.
Well, it's really groundbreaking in terms of what not only our board, but also our departments are recommending. One of them is going beyond just being a safety net for the very poor and the most vulnerable. This is about really taking care of everyone. And we pride ourselves, of course, in better health for all. We know that over the last 2 years has been very difficult for individuals and families as they've been isolated. The increasing rates of anxiety and depression because of COVID-19 and the economic uncertainties all around us, it's really impacted everyone. I think the building on our strengths, which is not only our talented staff, our team of providers, our caregivers, but then also the talent that we have and the willingness to go beyond what other counties are not willing to go, quite frankly. In this particular case is working with our partnerships to expand access and to be treating the patient not only as a whole person, but also equally in terms of the dimensions of health, meaning the medical side as well as the mental health and other addictions. I think this is really groundbreaking. You're both addressing the policy and some of the gaps, even though that's might be difficult because a lot of the solutions are at the federal state level, but you're also dealing with some on the ground issues in terms of real-time access. The last point that I'll make is that more than 60%, and Dr. Smith will know the statistics, more than 60% of the medications are issued by primary care doctors trying to deal with mental health conditions and substance abuse. And I think this approach that Ms. Rosas is offering in terms of bringing that together in a very integrated fashion is really taking us in the right direction.
All right, thank you for that. Dr. Smith, you want to get a word in edgewise here?
Well, I think that Renee has captured a lot of it, but I'm very proud of it too. I mean, this county with the leadership of the board has made the commitment to provide service to not only the underserved, but all of the individuals in our community that are in the missing middle, those that can't get insurance for whatever reason, and also those who qualify for covered California. And this is an important step forward. And we're hopeful that other counties will join in the effort. It's really a minimal amount of resources for a huge positive in the community to be able to provide behavioral health services. And we think it's a great step forward.
All right, thank you. And let me just also say, I have on occasion made the observation that it's one thing for individual board members or the entire board to say, hey, we've got a notion, we've got a thought, we have a vision, but ultimately we all know that only gets realized if staff steps up and makes it real. So to everyone who is taking these, I think, good ideas and making them real, I just want to say thanks again.
Thank you.
I should say, Ms. Rosas and Mr. Santiago and Dr. Smith, I am acutely aware of the fact that we can have a program in place, but ultimately, if there aren't any providers, just because there is a shortage in the field, that is going to be a significant impediment to our efforts. And I just want to let you know that I know that. That's why I so appreciated when we had the larger discussion recently at the full board level that we had the conversation about, what steps we can take, however modest, to expand the pipeline of folks who can provide these services. Let's check with my colleague Supervisor Lee, see if he's got any comments or questions before I ask the clerk to tell us whether we have folks who are queued up to speak to the item.
Yeah, thank you. Thank you very much for this very exciting report. And like Dr. Smith says, it's actually quite surprising to see the incremental cost that's added, but what amount of coverage that has expanded is truly amazing, especially we're talking about A, going to mental health, B is the fact that we are going to a 650% FPL, which is significantly higher than 400 FPL that we've been working with. And I guess my question in terms of the calculation is the additional $1 million seems to be fairly small compared to how many more people we're covering. And where are most of the cost savings come from? Is it because of the fact that the system is already in place, so the additional coverage of people was fairly small?
That is correct. We looked at utilization data and compared it across our lines of business and did some forecasting to get to that amount. And if you look at the PCAP report that was part of the VHP monthly operations report, you'll see PCAP has dropped about 1,800 individuals, most likely because of the expansion of Medi-Cal, as we had expected.
Right.
So because there's been no recertification for Medi-Cal yet, and there's been no recertification of the PCAP members. So we expect that we'll see PCAP drop as the over 50 expansion occurs, which is what we're seeing.
Good. And how, so exactly how does that reduce the administrative complexity to improve this alignment of care by this expansion of the 650% FPL? Sure.
So if you think about it, if you have a patient who is coming in for PCAP and they've got it's to 400%, but we would say, well, okay, but if you have a behavioral health issue, now your income makes it more available. It's hard to message, it's hard to get in front of patients if they already assume they're not eligible. If HAP is covering the patient at 650%, and now they need behavioral health, or they need primary care, it just becomes very disjointed if it's not clear that it's 650% across the board. How many people in that higher income bracket are actually going to be eligible? It's hard to say. A lot of people in that income bracket have insurance, but it's still, if for people in that income bracket who don't have insurance, it's a real barrier to have different eligibility levels for different types of care.
Right. And this is really exciting because I know my colleague has always talked about the missing middle, right? And this is exactly what we are talking about, is by increasing 650 FPL, that's exactly what we're covering, is the missing middle will be covered, correct?
That's correct.
Great. All right. And at this point, that's all I have. Thank you very much.
Great. Thank you so much.
All right, thank you. Let's turn to the clerk, see if we have any members of the public who would like to speak on this item.
One request to speak, Mr. Chair.
And let's hear from that speaker, please.
Michael Rogers, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Thank you for your time. I wanted to commend the county health system for this program. PCAP is really wonderful. Thinking back to the history of ACA in this county, programs for older couples ran in the range of thousands of dollars per month. So getting to 6 times the federal poverty level, currently, I just looked it up, gets you to about $108,000. So if you're spending many thousands on your living space and it costs you thousands per month before you look at deductibles, that's a pretty significant amount. So it's fantastic to provide offering the accessibility of care, and adding mental health is phenomenal. Talking to Dr. Smith's comments earlier about entities not providing services that they're contracted for, one, this is anecdotal information, but I know a number of people in Kaiser that find getting mental health care within the Kaiser system locally is practically impossible. The appointments are many weeks or months out in time, and we all know that mental illness has a long, significant amount of urgency to it. So there's a large classes of things that contracted providers are practically not providing for various reasons, whether that's paid for by an employer, paid for by Medicare Advantage, or some other program paid for indirectly by private entities. So one thought I had in these larger discussions that was very effective, I thought, in the early parts of the pandemic, was dragging these entities to the Board of Supervisors to explain what their data, where their data is at, and giving updates. They worked very effectively on the testing, which was very disparate in terms of who was providing it. There was an ordinance involved in that case, but I think just the fact of bringing them in to either Health and Hospitals or the Board of Supervisors might be an interesting suggestion to get their accountability, make them publicly. I know these meetings are covered and reported on in the press, so making wider awareness of where there are gaps in where they're not providing services that they're previously paid for. In particular, in Kaiser's case, they're paid for in advance. They made a ton of money during the pandemic when they were limiting the amount of services that they were providing when they're contracted to provide those services, no matter what. So in any case, thanks again for the county health system for taking a leadership role in this. These are great programs, along with whole person care and the stuff that the state is taking on and making a bigger part of CalAIM. Thank you.
That concludes our request to speak, Chairperson Simitian.
All right, thank you very much. Then let me just ask for a motion to receive the report.
So moved.
I will second. Let's call the roll, Madam Clerk.
Vice Chairperson Lee.
Aye.
And Chairperson Simitian.
Aye, thank you very much. And that takes us to the next item, item number 9, which is the Mental Health Parity for County Employees report. Let me ask who's going to be providing that report.
Yes, Mr. Chair, I think this is one of the additional items that was added to the original board referral, and we have Rhonda Schmidt from the Employee Benefits here.
Go right ahead.
Hello, Supervisor Simitian and Supervisor Lee. I'm Rhonda Schmidt. I'm the Employee Benefits Director, and I'm happy to address any of your questions.
Forgive me, muted again. Supervisor Lee, comments or questions?
Sure. Yes, thank you very much for the report, Rhonda. The report talks about going to be produced to us in 2024. And that seems quite a far away for such an important issue, especially one that our county is supposed to be taking a lead on. The May 9th of Gender report on wait time for the mental health care highlighted the dire need for the improvements. And I think it is certainly important that also be monitored closely. So is it possible to receive an off-agenda report with the aggregated data that helps us see how we're doing in complying with these parity laws with our own employees?
I am not certain that we'll be able to receive data from the health plans regarding this because they are still working with the Department of Managed Healthcare regarding reporting requirements to be in compliance, but we can certainly ask them.
Okay, yeah, if you could just get back to this because I don't think we should wait like a year and a half or 2 years or something this important. Obviously, the health and the mental health of our employees is so important. And I think if there's something that you could obtain early to us, that would be very helpful. Thank you. And that's all I have, Chair Smith.
Thank you, Supervisor Lee, and my apologies for the lag time here. I'm trying to make sure we have no back chatter, and it means every time I unmute, there's a little bit of a lag. Let me ask the clerk, do we have folks who would like to speak to this issue?
We do not, sir.
All right, well then, let me just ask Ms. Schmidt and the rest of the team, what would your best advice be to employees we hear from who say they have trouble accessing the services they need? Let's try it that way.
You said from the employees?
Yeah, I mean, I don't want to presume, I certainly can't presume to speak for Supervisor Chavez, but you know, she raised this topic in the context of mental health parity and specifically for our employees. And I think wanted to be sure we pursued opportunities to make sure that folks are getting the services they need and are entitled to. So if we have employees in our organization who express concern about their ability to access those services, what advice would you suggest we give them?
Well, I would certainly be interested in being informed whenever that's the case so that I can address that issue with the health plan providers.
Okay. And going back to your earlier comments, tell us again how you feel the providers are doing in terms of understanding and responding to the obligation that is already there in their contracts.
My understanding is they do understand the requirements and are working towards compliance.
Okay. And Ms. Schmidt, not to put the weight of the world on your shoulders, but are you literally the person to whom folks should be referred if they feel like they can't get the services to which they are entitled and that they feel they need?
No, I have a team, all of the service center staff for each of the departments are available to address customer service concerns from the employees.
All right. I ask because I want to ensure fidelity to the referral from Supervisor Chavez, but also because I raised this issue in a referral of my own some months back in connection with mental health needs at VMC and public health in particular for folks who'd been really on the front lines of the COVID challenge. But as Supervisor Chavez's referral suggests, and as I indicated as well, you know, clearly it's a system-wide responsibility. So I see Dr. Smith's hand is up. Let me go to Dr. Smith and take his comments at this time.
I just wanted to add a little bit to the issue of our employees and their insurance coverage. As you know, we really have three insurance providers that all of our employees have to choose from. One is VHP, and I think you already heard from them about their commitment to have mental health as a service that has parity with medical health. The other is HealthNet. They also do a reasonably good job of providing mental health services, and they are a PPO system, so you have some discretion about where you go. The biggest concern, I think, would be Kaiser, which is the third operator. As one of the speakers mentioned, Kaiser has limited mental health, at this point, limited mental health services available to members, although there's a commitment from them to the state to improve that access. And if any of our employees have problems with their health plans or their eligibility, they should talk to employee benefits, which Rondo runs, but there's a network of service centers throughout the county, and then a central access point, either by email or by phone, which can be gotten on the website in order to register complaints or change your program or deal with any other issues that are going on. And then just for completeness sake, the state Department of Managed Healthcare also has regulatory control over all of the managed healthcare plans, and the insurance commissioner has regulatory control over the insurance system. So benefits can refer you to those if there's a specific situation.
All right. Let me confirm with the clerk once again that we do not have speakers on this item.
That is correct, Mr. Chair.
All right, then motion by Supervisor Lee, please, to receive the report. Motion by Lee, second by Simidian. Please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye. Thank you very much. And that takes us to item number 10, suicide prevention. And let me just ask who would like to present here.
I will be presenting, Chairperson.
Thank you.
This is Bruce Copley, Director, Access Unplanned Services, Supervisor Simidian, Supervisor Lee. I'll start the ball rolling. Before you is the annual report for the suicide prevention 2021 year. It is submitted on behalf of the Santa Clara County Suicide Prevention Oversight Committee and its work groups. It includes the key findings, the major objectives, and the recommendations and next steps. I also want to take a moment to thank Vic Orjekian, who couldn't be here for our presentation. He's been a strong leader over the years as we've developed the suicide prevention plan in our county and really set the standard throughout the state. With that, I'd like to turn it over to Michael Manstock, who is a manager in the Prevention Services Division, and will lead you through our brief PowerPoint and answer any questions you might have on the substance of the report. Michael?
Thank you so much, Bruce. Thank you, Chairperson Simidian, as well as Vice Chairperson Lee. And thank you to all the participants and attendees for the opportunity to present this report. Just want to make sure everyone is able to see the cover slide of the report at this time.
Thumbs up.
Thank you, sir. So as we see, this is the Suicide Prevention Annual Report, October of 2022. As we're getting started in here, just like to take everyone quickly through the logic model as it relates to the program, highlighting the outcome objectives, and then also making a connection between these outcome objectives and the activities that the program provides on a daily basis. As you will see here, the ultimate goal of the program is to reduce and prevent suicide deaths within Santa Clara County. We attempt to operationalize this or achieve this as a program through these 5 outcome objectives. As I said, I'm going to make a connection here between these objectives and the activities that the program administers. Our first outcome objective is to strengthen the suicide prevention and crisis response systems within the county. And some of the activities that the program engages in order to facilitate this are the schools for suicide prevention programs, county health system trainings, as well as consultations through some of our contractors. The outcome objective of increasing use of mental health services within the county. This includes some community helper and mental health trainings, which are administered or provided by program staff. This is the Be Sensitive, Be Brave series as it relates to mental health and suicide prevention. There are public awareness campaigns, which I'll highlight in later slides and go more into depth as it relates to suicide prevention. There's various community outreach activities which are engaged in by the staff of the program, as well as various contractors. And then there's also the crisis text line contract, which is a service which allows residents of the county to text a crisis counselor if they're in crisis or in distress. The third outcome objective has to do with reducing access to lethal means. Some of the activities that the program engages in as a means to accomplish this outcome include gun safety communications, ligature restriction efforts, and at times possibly also media campaigns related to these two topics. In the outcome objective 4, we see improving the messaging in the media about suicide. Again, this goes back to a lot of our media monitoring. The communications work group actually monitors media reporting when there are suicide deaths to ensure that the way that they're reporting on these deaths doesn't lead to contamination or to other spreading of suicide within the communities. And then also there are safe messaging consultations and trainings to media reporting in newsrooms that are receptive to these types of consultations and trainings. And then finally, the attempt or the objective of creating supportive community environments. This is manifest through some of the work with Youth Connect, and then also the focus on increasing social emotional learning in the school systems. So these are just to make the connection between the outcome objectives the program strives for and the activities on the ground that are provided. And then finally, also we have some cross-cutting initiatives. Last year, the substance use treatment and suicide prevention services teams merged in a division, the prevention services division. And so in some of these instances, there's collaboration among the data and evaluation, policy implementation, and cultural competency as it relates to the entire division among these two teams. Transitioning now just a little bit from some of the objectives and activities to reviewing some of the most recent data that we have available. I'm just going to highlight really quickly as we're transitioning to this slide. We do have the raw data for suicide deaths in the county from 2021. Although due to the fact that the census is not yet available, we do not have rates from that data. So you're going to hear me talk about the data throughout the course of the presentation, largely focusing on the most current raw data which is available, with the caveat that rates are not available due to the limitations of the census. One thing that we see here is, generally speaking, over the past 5 years, as it relates to suicide count and rate, as we see, there were increases sustained from 2017 until 2019. But then as it relates to the raw numbers from 2019 through 2021, there have been declines in these raw numbers. They have been slight decreases. And again, what we do know about rates is that even if there are slight decreases in raw numbers, it might not translate to a rapid reduction in rate. But at the same time, it is worth highlighting that very slightly, the raw data is trending in a direction of a reduction in total suicides within the county from 2019 through 2021. Highlighting a little bit more in depth now some of the observations from the raw numbers that we have most currently, especially as it relates to some trends throughout the county. From 2020 to 2021, there was a decrease in the number of suicide deaths among females within the county by 10, which we saw reflected in the previous chart. That was the decline of 10 deaths. And kind of fascinating as well, the number of male deaths in the county due to suicide in 2021 remained consistent. And what we know nationally about suicide is the rates for males tend to be trending higher. So the fact that we didn't see an increase there in the county is something noteworthy, in addition to the fact that we did see this overall reduction. Taking a look quickly at some data related to age, the number of deaths for older adults age 65 plus, increased by 1 death from 2020 to 2021, while the number of deaths for young adults age 25 to 34 remained the same from 2020 to 2021. So, again, we're seeing just from the raw data from 2021 that there weren't increases so much in a lot of these categories, age, genders that we think of as high risk. There was and just looking a little bit at some of the ethnic data from 2021, there's an increase of 2 suicide deaths among members of the Asian community within Santa Clara County from 20 to 2021. While in the Black community within Santa Clara County, there was a decrease of 4 suicide deaths from 2020 to 2021 from 5 to 1. So again, we're kind of seeing broadly here some of these reductions in raw numbers. And then also highlighting in this slide, the number of deaths in which firearm or hanging were the method of suicide reduced. And this is noteworthy because we know just from data and research that the most frequently utilized methods of suicide death are firearms or hanging. So the fact that we saw a reduction of 12 deaths from 2020 to 2021 by firearms and suicide by firearms, as well as 19 deaths in suicide by hanging, is something that we would want to notate, and we'll connect with later slides which talk about the program's outreach efforts and education efforts pertaining to firearms as well as hanging. And we saw from some of the stressors, this was a review by the medical coroner examiner, the top stressors that were learned or known based upon review were unknown, intimacy, diagnosis, job, and conflict. One thing to notate that the staff who did the review and analysis here wanted to highlight was that in the unknown conflict, that did include bullying and included other sources of interpersonal distress. So it's important just to make it known that this unknown category actually encapsulates some pretty interesting stressors that are worth knowing about and guiding our efforts moving forward. I'm going to highlight some of the efforts here throughout the entire larger county on behalf of the program as it relates to youth suicide prevention. One thing that the program's particularly proud of was in fiscal year 22, the program entered its 4th year of the partnership with school districts participating in S4SP. And as you can see here from the chart, in the 4th year, a total of 17 districts with varying prevention needs and technical assistance were reached. And that actually reflects, in those 4 years of the partnership, more than 15,000 teachers, staff, and students having been trained in various Cognito simulations. Cognito is a simulation that allows students to go through scenarios in which their peers might be in distress, experiencing suicidal ideation, and allows them to actually role play and learn skills and tools to adapt to this and to report it. It also allows teachers and staff the ability to go through these simulations to receive practical training in suicide prevention. In 2020 to 2021, during the academic school year, even though the pandemic was in effect, Cognito training was rolled out online, and even in the 2021 to 2022 school year, over 2,000 school staff and approximately 1,000 students were trained in online Cognito modules. So again, a lot of really great outreach being done in the school as it relates to not only training staff, but also students as well in suicide identification and prevention. In fiscal year 22, the HERD Alliance team completed 51 consultations and trainings in social emotional learning or crisis response with 95 administrators and staff from 17 participating districts. And then finally, just highlighting quickly the Youth Connect initiatives in Palo Alto. These worked on looking at and evaluating outcomes on belongingness and connection among youth and expanding the program to other cities. Peer leaders from Youth Connect hosted informal presentations. They trained other students as well as staff in Be Sensitive, Be Brave. And they also had a call to action workshop development. Highlighting some of the program's effort as it relates to ligature means safety and public awareness campaigns to support suicide prevention throughout Santa Clara County. In fiscal year 22, the Suicide Prevention Communications Work Group planned, developed, and implemented a comprehensive public awareness campaign to support suicide prevention through safe firearm storage in Santa Clara County. The campaign's primary objectives were improved knowledge about best practices for safe firearm use and safe gun storage. And we see that public awareness campaign about Save a Life, time between you and the loaded gun can make a difference in the slide. We also see that essentially this was other information gauged or in attempting to increase safe firearm behavior, including use and storage practices among county gun owners and residents with firearm access. The program also participated in a gun buyback effort throughout the county and continues to do this, working with other various stakeholders throughout the county. This program also worked on addressing ligature means safety based on county suicide data showing that hangings have become the most common means for suicide. And this is especially prevalent among youth who were of non-white racial and ethnic groups. There was a lot of communication focused on hanging means safety. There were 2 roundtables conducted centering on suggestions for prevention strategies. And there was also a work group formed to focus on this topic. We see here that there was a brochure created, which was focused for family members as well as community providers in order to provide education and information about ligature means restriction, as well as suicide prevention in the community for people at risk of engaging in suicidal acts with ligatures. We take a look now at some of the coordinated and culturally responsive system of clinical care for suicide that was provided through contractors to the health system. This was between the Community Connection Psychological Associates and various other county stakeholders. As you see here, the description is provided for anyone to review. I'm not going to read through it word for word, line for line. But basically what the focus of this was on improving and supporting culturally competent suicide prevention management and the county's clinical services, targeting both behavioral health and ambulatory care stakeholders as initial sites. One of the most exciting successes that occurred in fiscal year 22, especially among ambulatory and behavioral health care clinics within the greater health system, was the initiation expansion of group therapy offerings through primary care behavioral health clinics. These groups allowed clinics to handle high patient flows and to buffer the transition process for patients awaiting connections to individual therapy. It improved access and it actually increased retention in some instances as well. And then also one thing to highlight was the team from Community Connection Psychological Associates conducted a organizational needs assessment with momentum at the end of fiscal year 21. And in fiscal year 22, they completed a 6-month suicide prevention training series with the staff of Momentum, focused on cultural and underserved populations, treatment and comprehensive assessment, community support for following suicide loss, paperwork, policies and procedures, and crisis in 5150. And as a result of this work, the organization completed a number of lasting changes, and they continue to revisit these monthly trainings in order to keep the topics of suicide prevention and culturally sensitive suicide prevention fresh within their team's minds. I'm going to talk quickly about some future directions. We're going to continue as a program to sustain and grow our current efforts, and we're especially going to focus on identifying or developing evidence-based evaluation methods of professional practices, which allow for the measurement of services provided focused on socio-emotional learning environments and crisis response systems within school districts throughout the county of Santa Clara. I'm going to continue to identify and implement joint efforts with the substance use prevention. Just a quick additional bit of raw data from 2021. Suicide deaths by overdose, which this is the number of deaths by drugging or poisoning as the method, increased by 3 from 2020 to 2021 within the county. And so again, as a result of this integration of these two teams, going to continue to figure out and to focus on, how we can do outreach and formulate program-related strategies to focus on these deaths by overdose in these social emotional learning environments. We're going to continue the pursuit and analysis of suicide data. The medical coronary examiner has launched a data dashboard, which has made some of the process of obtaining the county suicide death data a little bit more timely. although it's still a work in progress, but we're going to continue to pursue the analysis of this data in a way that can allow us to do it accurately, but still try to get it out as timely as possible. And then moving to taking some questions and comments, I did just want to quickly highlight in this final slide that in order to get direct access to the Santa Clara County Crisis and Suicide Prevention Lifeline, please call 1-800-704-0900 and press 1. That's the most effective way. I was asked to kind of message for members of our community to access our Crisis and Suicide Prevention Lifeline. I want to thank everybody for the opportunity to offer this presentation and take any comments or questions.
Thank you very much. Let me turn to Supervisor Lee, see if he has comments or questions to begin.
Yeah, thank you, Chair Simitian. Thank you for the very informational report regarding the various circumstances for this very difficult topic. When we look at the data, and I'm trying to understand, relative to the, looking at the different ethnic background, it looks like the Pacific Islanders have a very high yearly suicide rate per 100,000. Looking at slide 8 of the suicide data report. I'm just trying to understand if there's any way to find out the reason why, and are we doing any type of intervention targeting the Pacific Islanders, and also in addition to the telenoas that's highlighted on page 30 of the annual report?
I want to thank you for your question, Vice Chair. And yes, thank you also for that attention to detail and noticing how that data visually comes off on page 8. There were 2 questions in there. And so one I wanted to directly mention is that in addition to the telenoas, we do have a subgroup. We have an interventions work group, and then we have a subgroup of the interventions work group focused specifically on Pacific Islanders. Mm-hmm. So that subgroup is in place. And then in addition to that, if I could say a little more, I had spoken to a community outreach specialist within the program, and we are working, the team is working on trying to host an annual suicide prevention event starting in May of 23, targeting specifically the Pacific Islander population. In addition to that, we would like to, as a team, develop some type of survey so that we can increase the data that we have on the population. Survey specifically for the population, maybe to learn more, maybe about some of the stigma, the barriers, those sorts of things. That's something that's in place. And then the data from the survey will hopefully be used to create specific Pacific Islander resources, outreach strategies. I could kind of speculate a little bit just based on our menu item of options, but I don't want to do that. But the data will drive and inform which practices the program will engage in.
Okay. And looking at the map also in terms of the location where these suicides are occurring in our county, there appears to be a higher concentration in the South County and parts of San Jose, including the central, southern and eastern regions. Do we have anything to target some of these areas?
Yes, thank you. And actually, I was presenting on this data at our suicide prevention conference in the past 2 months or so, and somebody else had highlighted that. So I appreciate that the data is coming to the attention of people's eyes. And so let me respond here kind of broadly. The program's efforts are data informed. So the program's going to tailor their efforts, whether it be campaigns, outreach, trainings, other activities based on a wide selection of data. A lot of the work that we're doing is driven by this, and we're always going to aim to capture the needs of specific groups within the census, whether it be race, ethnicity, age, gender, on all of the available pieces of data we have at our disposal. So in using these variables, to guide campaigns or outreach effort, we do reach folks who live in these areas, especially through using these broader awareness campaigns. And then we also continue, as was referenced earlier, but I think it's very important to kind of highlight, we support the South County gun buyback events in recent years and actually participated in one of the more recent ones, I believe, in North County, and are also planning on participating in one in South County later this year. Some of the things we're doing is providing gun locks and information, that kind of stuff. And then actually more specifically, even some of the examples of the specific prevention or intervention efforts in these regions include Bill Wilson Center has a response and grief support team and program that is deployed following community losses. And so whenever that occurs, they're more than able and willing to do that. And then also there's training in peer support and other collective bargaining organization staff in critical incident stress management, also by Bill Wilson. And those services are deployed throughout parts of South County, as well as the central, southern, and eastern regions of San Jose. The program, as I kind of alluded to in some of the school-based work, we partner with school districts around access to cognito training for educators and staff, which is focused on identifying students who are in psychological distress and might warrant referral, that early identification, early intervention model. And so that's deployed in the regions that you were describing. We do host specific South County trainings for Santa Clara County providers from South County. So we are kind of trying to provide skills and tools to the staff who are there doing the work on the ground. And then there's a South County Youth Task Force Mental Health Committee, which actually includes members from previous suicide prevention work groups, whether it be the interventions work group or the oversight committee. So there are some members down there. And so they're also kind of engaged in this work group in South County, trying to improve access and mental health for youth. And then also our community outreach specialist is tabled at Morgan Hill. And then I don't want to presume, but I believe, if they've done that before, the outreach will continue. And then there's also been our programs, Be Sensitive, Be Brave trainings on mental health, as well as suicide prevention, which has been provided community solutions. And I haven't worked out in behavioral health in the community for quite a while, but when I did, Community Solutions was a real, a large organization in South County delivering quite a bit of services. So the fact that we're engaged with them is obviously in providing our trainings for suicide and mental health a positive step.
Okay, great. Thank you very much.
Thank you, Supervisor Lee and Mr. Manstock. Let me just ask, and/or Mr. Copley, is the decrease in suicide among women statistically significant in a way that allows us to conclude that there's good news there beyond the one-time drop, or are we not able to draw any kind of conclusion like that just because the time period is relatively limited and the numbers are not sufficiently large to provide that kind of statistical certainty?
I'll take a stab at this, and Bruce, if you'd like to add anything, feel free. I have to remain, as the program manager, I'd love to correlate some of our activities to that or that kind of thing, but the reality of it is we don't have the ability to draw a correlation there yet. And more information and more data would need to be researched. But I'll defer for a moment.
Yeah, I would agree. I mean, a point in time reduction without some additional analysis, it's hard to say whether it's a positive trend or not. We also have the COVID issue that may mitigate some of that, but it's going to take a longer term review to really see if the trend actually is in the right direction as this would suggest.
Okay. Next question, probably to Mr. Manstock, is there was a passing reference to the YCS program, Youth Community Services, in the Palo Alto area, and I thought I heard you talk about expansion of the program to other cities as a possibility. Could you tell us a little bit more about that? It's obviously an activity in my district that attracted my interest and attention.
So I'm going to be transparent here and say that's something that I would have to do some more research on, and I would feel uncomfortable asking or offering an answer to that without, doing a little bit more, because that's just my transparent, respectful answer there.
Got it. Thank you for that. Nothing wrong with saying you don't know enough to give an answer. There's better that than making it up. So why don't we ask for an off-agenda report, sometime in the next month or two. Is that fair, Mr. Manstock and Mr. Copley?
Yeah, of course, of course.
Okay.
We'll get back to you in a month, Supervisor.
All right. Then if I were to sort of ask you to, say, all right, sifting through all of this, what should we be doing in the future to hopefully make progress? It sounds to me like what you said is keep doing what we're doing along the lines of what Mr. Ojakian said, which is to, stay on it. Don't let our foot off the gas on this one. Is that a fair summary?
Absolutely. And I would even double down with what Vic said. Sure.
Okay. Anything in particular that you wish we had the ability to do more of, or that you think is paying particularly good dividends in terms of suicide prevention?
One thing I would quickly say is, the more ability to analyze data and collect data we have, the better we're going to be able to inform our efforts. So anytime we're improving our data collection, our data analysis system, we're going to be able to do more effectively targeted outreach and, just notice trends as they develop, kind of similar to what Vice Chairperson Lee was highlighting with that trend in demographic data. So as we improve our data collection and analysis system, things will continue to improve. I know this is probably an answer that you hear frequently, but the more staff we have that we can put out in the community to do outreach, to provide education, to reduce stigma, to have peer mentors telling their stories, to increase access, that's something else that's going to improve outcomes, I would assume, broadly within the community. I'm going to pause here because I could probably keep going quite, just off the cuff, but those are well thought out, pretty well articulated things in response for now, sir.
All right. Well, I will say thank you then and ask the clerk one more time. Any member of the public queued up to speak on this item today?
No requests, Mr. Chair.
All right. Then Supervisor Lee, can I get a motion to receive the report?
So moved.
All right. And we'll say thank you to the whole team as I say second that motion, and let's call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye. Carries unanimously. All right. Thank you again, gentlemen. And thank you to your teams. Please pass that along. That, I believe, takes us to item 13, the update from the director, since we made items 11 and 12 consent calendar items.
Yes, good afternoon, Mr. Chair and Vice Chair. We have operational updates for each department. As part of my report, most of the updates are related to the legislative approvals that happen and signatures by the governor related to this legislative year. We do have Ms. Kelly Brooks here in case you have any specific questions to bills or budget actions by the governor and how they might impact us here locally. So that will conclude my report before you let me know how you want to proceed.
Well, just to note that worth calling out that the legislation to permit a broader distribution program for surplus medication, which is near and dear to my heart, was signed by the governor. If I am reading my notes correctly here, this is the bill that Senator Becker carried at our request. So thank you for that. And why don't we ask that at our next meeting of this committee, we get some thoughts from the administration, Mr. Santiago and others, on what that additional flexibility permits in the way of expansion of the program. Is that a clear enough request, Mr. Santiago?
Yes, absolutely. We'll incorporate it for our next agenda, Health and Hospital.
All right. Thank you for that. And other than that, I don't have anything I wanted to reference that wasn't covered in the written report, except to say thanks to Ms. Brooks and her team for their work. Supervisor Lee, anything on this piece of the report?
No, thank you.
All right. Thank you again. And that takes us to the report from the public health officer, which would be 13B, but we have received that report unless that public health officer wants to share anything else at this time.
No, Dr. Cody has stepped away for another meeting, so not unless you have any questions or things you want us to follow up.
No, except for the item, obviously, where we made a formal request or direction from our committee to tee up the issue of vaccination responsibility as a legal matter. Then, without objection, Supervisor Lee, I'll move on to item 13C, which is a verbal report from the Chief Executive Officer, VMC. Mr. Lorenz, I think I saw your cube somewhere on my screen. There you are. Anything additional you'd like to share?
Supervisor Simitian and Supervisor Lee, I just wanted to just share with you that the 3 hospitals continue to have a very high census in terms of patients. And as we look forward to the winter months and flu season, we are looking to make sure that we build our capacity in terms of the additional beds needed going forward. And I think during our last meeting, we did talk about the ED volume and the demand on your system. So we are operationally looking forward to the coming months to ensure that we can better serve the community. The other note regarding our patient census, because we've been full at the 3 hospitals, our ability to repatriate patients from other hospitals that typically we would want in our system has been challenging. But I share that with you, knowing that we are looking to build additional capacity going into the winter months.
Mr. Lorenz, we can all recall 2.5 years ago the initial concern about flattening the curve on COVID and making sure that we had the surge capacity if and when it was needed. We thankfully are not in the position where that's the case at the moment. Don't anticipate that it will be the case, but are you feeling confident that if and when things took an unexpected turn, that the ability to surge is something that you all could respond to successfully, the need to surge if it happened?
I do. I think our system has the ability to flex and redirect resources to ensure that we're meeting the highest priorities of the community in terms of need.
All right. Supervisor Lee, anything for Mr. Lorenz before we go on to 13D?
Yeah, thank you, Mr. Lorenz. The question is regarding, as you said, the census is starting to pick up. So we are concerned about whether we have enough beds coming to winter months where we expect the numbers to go up. So one of the questions is also the usage of ER and how the numbers are so high right now. And I was talking to some of the doctors yesterday, and they were talking about how if we hire more doctors, like extra help type doctors at the community clinics, they believe that would help alleviate a lot of the need of people going to ER. What do you think about that type of strategy in terms of getting more doctors hired there and potentially even giving a slightly higher rate for these doctors so that they are going to be attracted to work with us as these extra help doctors?
So thank you, Supervisor Lee. So it is a multifaceted problem, and I would agree that expanding primary care is key to ensure that people have access to preventive health services and timely care. It is also important to understand that urgent care centers are also critically important to deal with same-day access issues. Mm-hmm. And that is something, as you well know, we are looking to expand, not only in the South County, but in other parts of the county. So it is a multifaceted problem whereby, yes, increasing access from an outpatient standpoint is a means to reduce the demand on the ED.
Right. So I think the investment actually, I think in the long run will save money. I think that's what the idea is, and also provide better urgent care access, like you said, because as we know, the ED wait time oftentimes exceeds an hour or 2 hours, depending on time of day. And with urgent care, I think a lot of the less serious issues could be dealt with, number one. And number two is it's actually quite profitable for us, because the way we get paid, I believe, is by per head coming in, right? So especially if the ailment is not very serious, I think at the end of the day, I think we actually have a better financial model by having more people treated at urgent care than having people stuck at the ED. Number one. Number two is if the patient get the urgent care taken care of closer to their home, obviously they won't have to come all the way to the big hospital for the emergency. So I think it in so many ways is financially sound. Number one. Number two is it's also better care for our community as a whole. Do you agree?
Yes, I would absolutely agree with those comments.
Okay, great, thank you. And so if you could let us know what type of plans in place in terms of trying to maybe hire, like you said, hire more medical professionals at these urgent care centers to allow more appointments being covered on weekends and whatnot. I certainly really like to see what type of efforts you're doing. I don't know if you want to provide to us as a verbally or as an off-agenda report. Either way, I certainly appreciate it. Thank you.
Yes, sir. We'll include that in our next operations report.
Okay, thank you.
If I may intersect here,
please.
I've been in healthcare, particularly in public healthcare, since the 1990s, and there is obviously a lot of truth in terms of expanding primary care, urgent care, alternative ways, more cost effective. I've personally have professionally experienced that even with a 40% increase in access or a very specific increase in access, it doesn't really save money. And even when we've had compression of hospitals and reduction of hospitals and even some closure of hospitals in different communities, somehow or another healthcare expenditures go up. So I would caution that hypothesis related to saving money. I think it's still the right thing to do, still the right thing for us to provide timely access to care, have convenient care, prevent problems from becoming even bigger problems. But the dynamics is such that, quite frankly, healthcare expenditures in America continue to increase. And of course, we need to continue to provide the care in all the settings, whether it be acute settings or subacute or an outpatient setting.
All right. Thank you very much. Supervisor Lee, okay with you if we move on to what will be 13D, Behavioral Health Services?
Yes, hi, good afternoon, Chair Simidian and Vice Chair Lee, Sherry Terrell, Director with our Behavioral Health Services Department. You do have our written report. I think the one area I would like to highlight for the public is that our county 2023 Mental Health Services Act annual update plan is posted, as well as our 3-year plan. And so it is posted for public comment until October 26th. So just really encouraging the public or anyone interested in, being able to weigh in on that plan to please do so. We really welcome those comments. Thank you.
Thank you, Ms. Tra. I think the only thing I would add today is an exhortation to please stay on 988, both in terms of public awareness and making that system as close to 100% responsive as any human system can be. I just think we knew when this came online that it would be a big lift and that wouldn't be as simple as flicking a switch. But I think I just want to exhort you to stay on it. And I also would say, I think for those of us who work in this field, it's easy to think, well, everybody knows. And I won't put my colleague too much on the spot, but I'm guessing Supervisor Lee will nod and smile when I say everybody doesn't know. This is a new tool, new vehicle, and it's going to take time for it to become fully appreciated, understood, embedded in people's awareness. Supervisor Lee, I see you leaning in.
Yes, I would say I can't say it better than you as Chair Submidian of the importance of 988 and getting the word out of this one-stop program. So I certainly want to encourage our staff to do our best to get the word out there, and I'm really looking forward to see it being implemented and some good report coming back. Thank you.
Thank you. Thanks, Mr. Rao. We'll move on then to item 13E, Valley Health Plan. Ms. Rosas, we have heard from you in a different context, but anything else you'd like to add to what we have already received and heard?
There are just a couple of things. We are now over 211,000 members. We've held that for a couple of months now. Our Medi-Cal is up to now 157,000, and we've seen a drop in PCAP, as I mentioned earlier. Open enrollment for Covered California begins November 1st, so we're gearing up for that. You saw some of our new branding in the deck that I used earlier. You'll be seeing that everywhere as we start to push out the enrollment for Covered California. And those are really my updates.
Thank you very much. I have nothing further. Supervisor Lee, you okay if we go on to the next item? Thank you. That takes us to item 13F, Emergency Medical Services. And Ms. Lowther, welcome. Anything you'd like to add? You know where I'm going to go in a minute. So
Good afternoon, Supervisors. Jackie Lowther with EMS. And I'm sure, as you can see, we are 3 months with the provider as far as being non-compliant, as well as partial for May. The provider is currently trying to reconfigure course staffing with their labor unions in order to become a little more progressive and competitive in the whole labor force. However, they will be receiving a second letter from us in collaboration with our county council to reinforce their continued non-compliance. Our first responders are responding well, and you will be receiving a report next month as far as our updates on 2024. This is the 5th month consecutive. We have had call volume in excess of 8,000, as well as close to 275 plus per month. Last month, in addition, we had an excessively high bypass numbers. You do not have the ambulance offload times, as there wasn't time to gather all of that data. You also have the domestic violence report, but I'm sure you have some comments you would like to share regarding compliance.
Yeah, I think mindful of the hour, I'm just going to say, I'm going to ask that you come back, and I should give a nod here to Dr. Miller as well. Good to see you. I'm going to ask that you come back at our next meeting with a clearly articulated pathway towards compelling compliance. I've been raising this issue over the last few months. I know you've been attentive to it as well. I hear you that the vendor knows that they're not in compliance, but after 3 months, this is, I think, undeniably now a trend, not a blip, and we have to address it before it becomes an even more deeply established trend. And I'll just ask that you come back with a work plan, if you will, for achieving compliance. And Dr. Smith, can I ask that the larger administration play a role, if necessary, in making that happen?
We surely will.
Thank you. Supervisor Lee, anything else on this item?
No, thank you.
All right, thank you, Dr. Miller, and thank you, Ms. Lowther.
You're welcome.
That takes us to 13G, custody health. Dr. Day, are you with us? There you are. I had Dr. Day.
Yeah, Mr. Chair, we have Pratima Padney, who's the administrative manager. Dr. Day is in the middle of other affairs right now. She can't pull away from.
All right, understood. Ms. Pandy, anything you'd like to tell us, or shall we just see if there are questions? I have none for today. Supervisor Lee, do you have any?
Yes, I just want to ask if we could update some of the slides we have regarding the vaccination of our population in both the main jail and Elmwood. Namely, right now they're still listing as the fully vaccinated, partially vaccinated. As we know, we changed those nomenclature once we started the boosters, and now of course we have a new booster. So I would love to see if they could get that updated to find out how many of those in our main jail in Elmwood have received the bivalent boosters, for example, the new shots, and if we can get that number as being an updated vaccination, I think would be helpful.
Good afternoon, Chair Simitian and Supervisor Lee. Pratima Pandey, Admin Services Manager for Custody Health. We will provide that as part of our report next month.
Great. And then
ongoing, sorry.
Right. And what's exciting to me is with the new bivalent vaccine now, I mean, I personally just got it myself, and I think it'd be good to offer that in the scale so that those who are in our system understands that this is something that's truly needed. The fact that they are so-called fully vaccinated for the first 2 shots is really, well, I'll say the word is basically lapsed, outdated because of the waning immunity issue. And given the living conditions in our system, their risk is certainly higher, especially for those who are older. So I would certainly want to make that booster shots as available as possible. Thank you.
Thank you, Supervisor. Absolutely.
All right. Ms. Pandy, forgive me. I asked if you had anything else you wanted to share and then didn't really give you an opportunity to share it. So anything else you'd like to share?
Nothing additional. Thank you, Mr. Chair.
All right. Thank you very much. And that takes us to our final subset of issues here. Item 13H is a report from on federal health policy and budget landscape. I see Mr. Margolin is lit up. Mr. Margolin, what would you like to share with us today?
I have a brief report today since Congress is out of session, but there are a couple of points to make. First of all, the federal government is funded through December 16th as a result of the continuing resolution, which was passed last month. The House and Senate will come back on November 14th for a lame duck session. At a minimum, during this lame duck, there will be an omnibus appropriations package approved that will fund the government for the remainder of the fiscal year. There's no way in this environment that doesn't happen. Not only is there not an incentive for either party to shut down the government during the lame duck, but there are a number of earmarks now in this appropriations package, several $1 billion worth of earmarks that both Republicans and Democrats want to see implemented. So combination of no political incentive to shut down the government and the earmark funding guarantees that we'll have a package approved in November, December. Now, how much else gets done beyond the basic appropriations bills is going to depend in part upon, or large part upon, what happens in the election. Is this lame duck the last opportunity for Democrats to act before Republicans take control of both houses or even one house? What incentive will the Republicans have to cooperate if they're going to be taking control of one house or both next January? So election results will determine the potential for other actions. Now, there are a number of health issues that could be acted on during the lame duck session. I'll just tick off a few of them. There's the issue of COVID funding. There's the administration's $22 billion request for COVID funding that was not acted on earlier. It's still pending. That's money for vaccines and testing. Right now, there's still little Republican interest in supporting that. It takes bipartisan support to get that done, but that'll be out there in November, December. There are issues like the cap on insulin costs for the commercial plans. The insulin costs under Medicare were capped in the Inflation Reduction Act at $35 per month. There's an effort underway, a bipartisan effort, to get that insulin cap applied to commercial plans. Whether that happens or not in the lame duck, we don't know. There are Medicare cuts that are pending based upon this process called sequestration. Democrats and Republicans have always found a way to defer these cuts, and they'll probably do that again this year as they have in past years. We've talked before about the bipartisan pandemic preparedness package that Senators Burr and Murray have tried to put together to deal with future pandemics. There's been less talk about that recently, but it still could surface during the lame duck. We also have the potential for the end of the national public health emergency that's been in existence for some time now. The state of emergency expires this month. It's certain to be extended for an additional 90 days, but we might see an announcement in November or December that it's not going to be extended again. And what that has implications for is the extension of telemedicine services, telehealth services, and there'll be a need for some kind of legislative fix if, in fact, the public health emergency is not extended beyond this next round. Again, the election results will determine how ambitious and contentious the lame duck is, and we'll have greater clarity after November 8th. But there is one last point I want to make about the political environment on healthcare, and it relates to the House Republicans, what they put out in the way of a platform about 2 weeks ago. Kevin McCarthy released something called the Commitment to America document, which is his version of what Newt Gingrich did a couple decades back, called Contract with America, effort to sort of outline what the policy positions are. And there's a section in there called Achieve Longer, Healthier Lives. And in reviewing that, you see points of difference with the Democrats, primarily on prescription drug reform. Republicans are still opposed to what the Democrats did in giving Medicare the power to negotiate prescription drug prices. They referenced the Democratic plan eliminating life-saving drugs, and there's a point of difference there. But there's one area of bipartisan agreement, though, that's also worth noting, and that involves telemedicine, telehealth. Republicans like telehealth, as do Democrats. They want to see that continued and expanded. But the most insignificant part of this report, which is really an omission, which I want to highlight, involves the Affordable Care Act. There's no reference to the Affordable Care Act, no reference to repealing it, no reference to damaging it or weakening it. It's not mentioned at all. And it's now clear that Republicans, at least in terms of their sort of national policy thinking, have given up on their long-term goal of getting rid of the ACA. None of the Republican candidates in the battleground Senate contest, none of them are talking about the Affordable Care Act. This is the first time since 2012 that's been the case. Doesn't mean that if Republicans take control, there will still be fights over subsidies, premium subsidies, efforts to weaken the law, strengthen the law. There'll still be differences, but the fundamental push for a decade now to repeal the ACA by the Republicans is now over. And that's the last observation that I wanted to share, and happy to take any questions you might have.
Well, you saved the best for the last, in my view, Mr. Margolin, but thank you for that. I have no additional questions. I should just sunshine the fact, Supervisor Lee, that I have Mr. Margolin to share with us some additional thinking on the Medicare Advantage program and the ACO REACH program, which is the Accountable Care Organization's REACH. This has generated a little controversy in some quarters, and I thought it might be helpful to our committee to hear back from him about what that debate is about. So we'll hear about that at our next meeting. Thank you for that, Mr. Margolin. And I'll just turn to Supervisor Lee and say, Supervisor Lee, any last questions or comments? And then I'm going to turn to the clerk to see if we have folks in the public queued up.
Yeah, thank you, Chair, and thank you, Mr. McGowan, for the report. So from the little I could gather in terms of the key points, seems to me that despite all the fights between the parties and whatnot in DC, looks like the Affordable Care Act, at least for now, is not in dispute right now or being fought over in the near term. Is that correct?
That is correct. The Republicans are basically saying in their platform and in their various campaigns, they are not going to prioritize repealing the ACA. Having failed on several occasions, they've given that up.
Okay, great. So that's one. Second thing is, a lot of times the party and minority like to use the budget as a way to drag things out. So not passing the budget on timely fashion and causing this government shutdown. What you're basically saying is that looks like everything is pretty hunky-dory for now, and I certainly have heard the former President Trump trying to lay blame on the Republican currently in office for not create more problems to cause the government to shut down. But right now, as you could see, looks like there won't be such a problem that we should worry about, correct?
That is correct for this budget cycle, November, December. I do think if we have divided government next year, the potential for a shutdown is very real. But in the current lame duck environment, there's no real incentive for either side to do that.
Okay, great. All right. Yeah, well, the election's coming up soon, and by the time we talk again, we probably will figure out clearly what happened to the November election. So
yes,
and you mentioned something about the commitment with America.
Yes,
and you mentioned this similar to the contract. Was it Contract on America that
it was contract with America, I believe it was called, that Newt Gingrich did in 1994. Periodically, the Republicans have sort of tried to revive a similar version of that, and Congressman McCarthy decided to unveil his latest incarnation of that approach, which is to have a platform that all the Republicans nationally in the House would run on. He did that about 2 weeks ago.
I see. Okay. And I don't understand the platform well, in the sense that, I mean, we're trying to lower the cost of drugs, and they're trying to basically say that we should not lower the cost of drugs.
Well, they're saying that there are 135 life-saving drugs over the next decade they're projecting that we will lose access to by having the federal government cut down on the profitability of the pharmaceutical industry. So the argument really is you squeeze the pharmaceutical industry, yes, you give consumers lower cost drugs, but you limit their ability as an industry to research new cures. And the CBO said there'll be some impact there. I mean, they thought it might involve a few dozen drugs. I don't know quite where the 135 number comes from, but in the scheme of things, that's the balancing act. How much you squeeze down profits, how much impact that has on research, and also how much short-term benefit to consumers receive. That's their argument.
As a patent attorney, is my last life working with many inventors of various areas, including pharmaceuticals. I could guarantee you that is one of the biggest BS argument I have ever heard. But that's all I'm going to say. Thank you.
Well, I appreciate that response, and I will quote you perhaps to others on that point.
Please do.
Okay, well, that's a term of art I wasn't expecting to hear today in this conversation about the legal and the healthcare environments. Supervisor Lee, are we good to turn to the public at this point, if there are any folks queued up? All
Please
right,
do. Thank you.
Let me ask the clerk, do we have any members of the public who are in the queue to speak on item 13?
We do not, Mr. Chair.
All right, then let me confirm with the clerk. I believe that means we have completed today's agenda. Is that correct?
That is correct.
All right, then all that remains is for me to say, having completed our agenda today, we will adjourn today's meeting pursuant to item number 21 to our next regularly scheduled meeting, which is November 9th at 2 p.m. And it is still expected that that will be by virtual teleconference. Thank you to all who participated today, and thank you for the good work. Take care.
Thank you, everybody. Bye-bye.
Recording stopped.
The meeting has officially adjourned and the room will be closed.